offered to help us with the rheumatology curriculum. He's going to give us 3 lectures this week, Monday, Tuesday, and Wednesday every afternoon, and then he's going to help us out with lectures in future as well. So thank you so much, Dr. Soloway. You can start whenever you're ready.
Okay. Thank you.
Thank you.
All right. So, good afternoon. I am Dr. Soloway, and I've been doing rheumatology for 30 years, so hopefully I can share some of that information with you people in internal medicine, transition year, physician assistant, nurse practitioner, attendings, or whoever else would like to learn something. And this is a 3-part series of introductory lectures because I realize that you guys have had literally no training whatsoever in rheumatology. So if you think you know anything about rheumatology, I assure you, you don't. And the reason I know that you guys don't know anything about rheumatology is all rheumatology consults in this hospital system go to orthopedics. So right there, I immediately know that nobody knows what a rheumatologist is for, or what a rheumatologist does, or what we're capable of doing, or anything. I'm going to turn to my slides and get on with the lecture because the time is limited and I have a lot to get through. Just which button do I hit? This one here?
Yes.
Okay, great. So, all right, so what a rheumatologist actually does in real life, 50% of what we do is what you would consider orthopedics, or what we consider rheumatic, we consider it soft tissue rheumatism. So soft tissue rheumatism includes hand pain, trigger finger, carpal tunnel, tennis elbow, golfer's elbow, rotator cuff tendonitis, neck pain, limited motion of the neck, spasm in the neck, low back pain, knee bursitis, hip pain, hip bursitis tendonitis, foot pain, heel spurs, plantar fasciitis, Morton's neuroma. Everything I just mentioned can be injected and cured by a rheumatologist. Now, there may be rheumatologists that can't or don't have those qualifications, but a well-trained rheumatologist can do every one of those things I said and more. I just gave you I gave you the short list. There's literally several hundred things. The second thing we do is we are the internist that is going to figure out the situation. So the standard rheumatology consult, even at Johns Hopkins, you're going to get called on day 10 and the chart's going to be 45 pages long, and maybe they've had 3 bone marrow biopsies and 95 cultures and it's all negative, so therefore it must be rheumatology. Things like that can be largely avoided with a little thinking. If the joints are ever involved, which includes the doctor or student evaluating the patient, if all joints are examined and somebody knows inflammation, tenderness, pain, warmth, swelling of any joint, whether it's the toe, the ankle, the Achilles, whether it's the knee, the groin, which is the hip joint, the butt, which is possibly the sacroiliac joint, so the lower back, the neck, the mid-back, the thoracic spine, the ribs. If somebody notices a problem in any of these areas, they should call rheumatology first, because we will get the proper workup started and we'll find out. Maybe we'll think it's septic, maybe we'll just order cultures right away, maybe we'll get a bone scan right away, maybe we will think, oh my God, this is probably a malignancy, just get a bone marrow biopsy. Or we'll say, you know what, you don't need to consult ID, you don't need to consult oncology, hematology. Let me tell you, you have rash, you have fever, you have renal failure, you have this, you have that. So there's a differential diagnosis of 5 or 10 possibilities. Let's order the blood. If the patient's critically ill, we'll empirically use some steroids and we'll usually get them better. And frankly, if they're infected, high-dose steroids will smoke out an infection most of the time. And in a malignancy, it'll simmer it down for some period of time, until, again, the time time often has to play out to find certain diagnoses. Okay, so I think I went over this whole slide by telling you those things. Oh, sorry, it's me again. Okay, so since I didn't memorize this list, I'm going to tell you that we treat anything that has to do with bones, enthesis, which you don't know what that is, but I'm going to tell you, cartilage, connective tissues, joints, tendons, blood vessels, and mucous membranes. Okay? So I'm going to try and give you an example of each one, because again, this is an introductory lecture, and I want you to know what the terms are, because I can't give you a lecture on ankylosing spondylitis if you don't know what an enthesis is. I can't give you a lecture on psoriatic arthritis if you don't know what enthesis is. I can't give you an ulcer on Behçet's disease. I can't give you an ulcer on relapsing polychondritis unless you know something about cartilage or aphthous ulcers or things like that. So it's very important to get the language down today. So I show this merely to show that there's bone. So one of the things we treat is bone. And I want to actually, here, so, oops, wait. Okay, so the most common thing of bone that a rheumatologist treats is osteoporosis. So I brought this paper here just to show you a DEXA scan. So I'm not here to teach you about osteoporosis today. That's its own lecture. But just know that when you have a patient who you feel is at risk of osteoporosis or has a spinal fracture or a rib fracture without trauma, those are osteoporotic fractures and they should be referred to a rheumatologist. So the rheumatologist can do an assessment. They can try to find out what risk factors the person had and treat bone loss. And I will throw in, because I know you guys are studying for boards, that just so you know, so I would say a board question, you should know that the T-score in a postmenopausal woman, if it's more negative than minus 2.5, that's the definition of osteoporosis by the World Health Organization. So at minimum, you should know that. If somebody says to you, do I have bad or severe osteoporosis? Those terms aren't recognized, except there's one exception. If you have osteoporosis with a fracture, then you can be classified as severe osteoporosis. So if somebody says, oh, my T-score is minus 1.7, I don't have osteoporosis, well, that's called osteopenia. And the example I give the patients, I'll tell them, the difference between osteopenia and osteoporosis, at osteopenia you're 3 months pregnant, at osteoporosis you're 4 months pregnant. But it's really the same, and the only problem we have is that the drugs indicated for osteoporosis may not be indicated for osteopenia, so it does alter our treatment. And the other comment I'll make about osteoporosis, see, this is how I get diverted, and I won't finish the lecture. It is probably beneficial that patients are treated with injectable treatments, and I'll tell you why. Oral bisphosphonates are very poor absorption. If you brush your teeth, the drug binds to the toothpaste. If you drink tea, the drug binds to the tea. You can have nothing in your belly, nothing except the bisphosphonate. And you have to be standing. The package insert says 30 minutes, but in reality it's 45 minutes to an hour. So you try to find me somebody who is in the osteoporosis group. We're not talking about a 40-year-old healthy athlete. We're talking about an 80-year-old unhealthy person who doesn't get out of bed. If you can't get out of bed and you can't sit up straight or stand, you can't take an oral bisphosphonate. So when I get these referrals from the soldiers' home or these group homes, everyone in the group home is on Fosamax. Every single person. And granted, they all have osteoporosis, but none of them are being treated right. All they're doing is eating Fosamax, and it's not being absorbed. It's not possible. And the other thing, keep in mind that if somebody's on thyroid medicine, that has to be taken alone in the morning, and that should take precedence to their bisphosphonate. So again, another reason to be weary, or leery at least. Now, the boards, the question is, the answer is always Fosamax, because that's just the answer on the boards. But in life, that's not. Okay. So I go back here. So I mentioned, so I just told you we treat bones, and I gave you an example of bones. Here, I'm going to show you this example. I mentioned that we treat cartilage. So we treat diseases that inflame cartilage. So you see here some ears, okay? And the ear on the right, you notice that the guy has 2 earrings, or the girl has 2 earrings, but it looks like a guy's head to me, but I don't know. That was my sense of humor, sorry. But the other ear, you notice there's something wrong with it. Does anyone notice what's wrong with the ear? Okay, not all at once, but it's red. So the ear is red, the helix is red, okay? So, but look here. I don't know if you can appreciate. This part of the ear is not involved. So when a guy gets punched in the ear, gets a cauliflower ear, is wrestling, has his head mashed into the mat, the whole ear is red. When you have cartilage inflammation, this is cartilage. This here, there's no cartilage here. Up here, this is cartilage. Down here, no cartilage. The trachea, cartilage. So relapsing polychondritis patients who get arthritis and vasculitis, which is why I said, if somebody comes in the hospital with a fever, who could be a polychondritis patient, but you don't know that yet, if you see a joint that's warm, tender, swollen, inflamed, you gotta call rheumatology, and with a proper history, you can say, hey, you're short of breath and you have this funny noise. Oh, they have stridor. Oh, the chest x-ray shows narrowing of the trachea. They have tracheal stenosis. Oh, and by the way, when you were younger, did you ever notice your ear get red? Oh yeah, here on my phone I have pictures, like every 3rd Tuesday of this leap year, I get a red top of my ear and it hurts and blah, blah, blah. So, okay, so here's an example that we treat cartilage. Now, I don't particularly like this slide, but it's not my fault. So, what is an enthesis? Does anyone seriously know what enthesis means? So, enthesis is the structure that connects the tendon to the bone. So, everybody knows tendonitis, everybody knows osteitis, but nobody knows about enthesitis. Enthesitis is what distinguishes rheumatoid arthritis from the spondyloarthropathies. The spondyloarthropathy hallmark is enthesis swelling or inflammation. And this includes the Achilles, the ribs, the breastbone, the sternum. So the one that's really common, and this happens to be an ultrasound and it's not mine, this is a downloaded picture from somewhere, but I will tell you that right here in this area, you can almost see in the photograph there's a small bump there. That small bump is meant to represent the Achilles enthesis. So when I'm examining somebody's foot, and by the way, I'm the only doctor that will be able to tell you, and this includes you guys, I'm the only doctor that will examine everyone's feet. Because I want to feel this, and I want to feel for tendon nodules. Nodules in the Achilles, they could be tophus, they could be tendon xanthomas, they can be sarcoid granulomas, they could be anything. But unless you actually touch it with their socks off, you don't know. So, now you know what enthesis is. So, when that person comes to the floor or the ER or somewhere, and they're giving you a history of heel pain, but it's not red and you don't think it's gout, or they give you a history of rib pain, but it doesn't sound like pleurisy, and maybe they have it with arthritis, maybe they don't, maybe they have it with uveitis, the red painful eye. This should make you start to think about rheumatology and rheumatologic diseases, okay? Actually, so let's go back here. All right, so we talked about bone, enthesis, cartilage. So for connective tissue, I don't really think I have a picture, but connective tissue, I would look at and I would just say, well, connective tissue it's the framework, it's the collagen that just holds everything together. So when everything is wrong at the same time, I'm saying, gee, that sounds like it's some sort of connective tissue. I would say it's, to me, it's less of a literal term than a concept. Like a connective tissue disease, you get arthritis, but that's a joint problem. So if you have a joint problem, why is it a connective tissue problem? So some people refer to like fasciitis or cellulitis as soft tissue connective tissue problems, and they are, but they have better names like cellulitis or what have you. Okay, joint would be arthritis. Tendon would be tendonitis. Blood vessel disease would be vasculitis. And mucous membrane, and I think I have a photo for you. Mucous membranes are going to be mostly, at least the way I look at it in rheumatology, aphthous ulcers. So just a few quick examples. Small little ulcers that are painless, that's the type of ulcer you see in lupus, while a Behçet's ulcer is very characteristic, and to a keen eye who has seen many Behçet's patients, you can look at an ulcer and know it's a Behçet's ulcer by the beefy red borders, the large size, and the patient history of how often they come and go, and the intermittent or the periodic nature of how they occur. So I'm going to try to get to you, I'm going to try and show you the other photographs. So I wanted to point out, so here's your foot, and this is a description of inflammation. So this is the first MTP, metatarsal phalangeal joint. So these joints are the IP joints, okay? So the IP joints, they're excluded in rheumatoid arthritis. However, they're very common in spondyloarthropathies or gout. This happens to be inflammation of the first MTP, also known as podagra, which just translates to foot pain. But this has taken the sole name podagra when you have a swollen red foot or first MTP. So when you see this here, you cannot say this is gout. There's a great article in the 1970s, I believe, by John Bomilowski, and it says, the title of the article is "Podagra is More Than Gout," and he listed the 15 other things they found in a 6-month period of time in the first MTP. But anyway, I show you this for that reason, but also I want you to know that these are considered small joints, the wrist is a medium joint, and the knee or the shoulder and the hip are large joints. And that'll lead us to, I believe, well, let me see here. So the only thing I'm going to tell you about this slide, it's not the slide I prefer to use, but the white stuff that you see is fluid, and this is a biceps tendon rupture, and the area that looks swollen, I think, is the retraction of the tendon. But I wanted to just show a photograph of a guy from the office who had a rolled up bicep, and that's really what you're going to see clinically. You're not going to see this in your career ever, nor am I. But I want you to get the point that we do treat tendon problems, whether it's inflamed or, if it's cut in half, no, that's orthopedics. I don't sew tendons together. But I can prevent tendon ruptures by controlling arthritic diseases. Okay, so I think I'm out of order here, but let's just say that this slide shows palpable purpura. And so this is a vasculitic rash. And the vasculitic rash that's occurring on the skin in these small red spots that are slightly elevated, called palpable purpura, this would be an example of small vessel vasculitis. And there are dozens, if not hundreds, of causes of small vessel vasculitis. Some terms that you'll hear are used interchangeably, whether correct or not, would be leukocytoclastic vasculitis, because that's often what is seen on the biopsy. And then it comes down to, gee, what's in the immunofluorescence? Did they stain positive for IgA? If they have IgA staining, that was formerly called Hinox-Schönlein purpura, now it's called IgA vasculitis. If it's just leukocytoclastic vasculitis and it's only small vessel, and by the way, the reason I can tell you this is small vessel, not large vessel, is if it was medium or large vessel disease to the skin, you'd have a giant ulcer, you wouldn't have a small rash. And when I say small, I don't mean the area covered, I mean the size of the lesions. So if the lesions are ulcerated, then you're dealing with a medium or a larger vessel. So this type of rash has to, by definition, it implies something small is happening. Okay, so here's a picture of aphthous stomatitis. Well, it projects well enough to show you that. So clearly you can see there's ulcerations on the tongue, and I believe this is the hard palate. So this is a person with aphthous stomatitis. Probably the most common cause of aphthous stomatitis is going to be viral, and probably the next most common is going to be drug reaction. But the third most common is going to be rheumatology. So if you can name the disease, I can fit an ulcer to that disease. And then it becomes, is the ulcer small or large? Is it painful or painless, and so on? Is it recurrent or is it always there? That type of scenario. And then that would be a disease-specific topic that we would talk about in the future, or that we will. Okay, so the next thing I want you to understand, joints are either small, medium, or large. You need to understand that the distribution of the joints is part of getting to the conclusion as to what they have. So if somebody shows up with one small joint that's wildly inflamed and swollen, it's very possible that that's a crystal, gout being common, calcium pyrophosphate common, but it's unlikely to be rheumatoid arthritis. If somebody shows up with 3 medium joints, a wrist, another wrist, an elbow, all 3 inflamed at the same time, well, that doesn't sound like rheumatoid. It could be gout, but that sounds more like a spondyloarthropathy. That sounds more like disseminated gonococcal infection even. And literally, the list is hundreds of diseases. Any of the vasculitic diseases can present with inflammatory arthritis. The one thing about all these conditions and all these tendon and physis and cartilage and all these things that I'm telling you about, the one thing that they all have in common, they all give inflamed joints. They all do. So if you say, why is polychondritis seen by a bone doctor? By the way, rheumatologist equals bone doctor. Orthopedic equal bone surgeon. Orthopedic would not have any idea what's going on in this lecture, nor should they. And I have no idea how to replace a joint, nor do I have any idea how to sew up a tendon, or so on. So, the one thing in common, all of our diseases involve joints. You need to know what's a small joint, what's a medium joint, what's a large joint. You need to know that monoarthritis implies certain things, oligoarthritis, which is up to 5 joints, and polyarthritis, which is 6 or more. They all imply different things depending on which joints, where they're located, and when they hurt, when they're stiff, how long they're stiff for, and these are the things that you have to know. So when you're doing a history on somebody with joint pain, doc, my wrist hurts. Okay, how long does it hurt for? I don't know. Okay, what else hurts? Nothing really. Okay, nothing really, that means something. Why don't you tell me, what else is hurting you? Well, just my ankle. When? When I wake up. Do you limp when you go to the bathroom? Oh, I can't go to the bathroom, I can't stand up. So now you have a guy with an inflamed ankle with something else, and then that's how the history starts to evolve. Okay. So, this is repetitive. Okay, so the knees are the knees, and so these knee x-rays are not the best example, but they are an example of, here's your femur, here's your tibia, here's your medial joint space, here's your lateral joint space. You can tell that the medial joint space is narrowed with respect to the lateral joint space. So if you don't know anything else, you can agree that this space is half the size of that space. This is an osteophyte, or new bone formation. This is sclerosis. It's too white compared to the rest of the bone. Now I'll agree the picture portrays that of what looks like a demineralized bone, but nonetheless, I want you to know that we have joint space narrowing with new bone formation and sclerosis. Hence, we have osteoarthritis. Now, do we also have could be chondrocalcinosis. Not uncommon to see chondrocalcinosis in the knees, not uncommon to see chondrocalcinosis here in the knee. The fact that you've got osteophytes laterally is somewhat suggestive, especially with the lack of joint space narrowing, that there may be chondrocalcinosis. The other finding in chondrocalcinosis on the knee x-ray would be that there's tricompartmental disease, medial, lateral, and patellofemoral disease. Unfortunately, here we don't have that. But here we do have definite chondrocalcinosis. And again, we have medial narrowing, bony overgrowth or osteophyte, sclerosis. If you can see this right here, this is tenting of the tibial spine, like a tent. It's debatable, and I don't think anyone in the literature agrees, whether or not tenting of the tibial spine is definitely a feature of osteoarthritis. Personally, in most of the osteoarthritic knees I see, they do have tenting of the tibial spine. But there are many people that will disagree based on their own experiences. This, for whatever it's worth, could be what is called an osteochondroma, which is a loose fragment that is derived from the synovium and has really no purpose for this lecture other than I figured I'd mention it. Okay, so we're going to switch now from joints to blood vessels. So essentially this is now an overview of vasculitis. And I don't have a lot of time to give it, so I'm going to hurry up. So the blood's going to flow fast. So vasculitis is typically classified by the size of the vessel. That being said, some people classify it by the location. So I'll throw it out there. There's a condition called primary angiitis of the central nervous system. Well, whatever central nervous system vessels are involved, and they're only in the brain, that's primary angiitis of the brain or the central nervous system. So that doesn't imply size, but excluding that and maybe 2 or 3 things that I haven't thought of, you need to know vessel size and what problem occurs, what disease occurs based on the size of the vessel. And you must recognize this just like you have to recognize a swollen joint. You need to be able to recognize a swollen vessel, even if it's just a symptom. I'll give you some examples. So the first thing I wanted to tell you is that large vessel vasculitis, giant cell arteritis. This is the most common vasculitis, is large vessel giant cell arteritis or temporal arteritis. I'm thinking that maybe you've heard of this, but maybe just don't know a lot about it. For the board exam, what they want you to know is if you have an elderly white person who develops a unilateral headache with loss of vision, that's an emergency. And even though the treatment for giant cell arteritis is typically prednisone 60 milligrams or 80 milligrams a day, in the scenario of acute blindness, that's when you give pulse steroids. That's one of the few scenarios. And for what it's worth, you should know that the pendulum is swinging to biologics. Interleukin 6 inhibitor or Actemra is now neck and neck for first-line treatment. The rheumatology community is sort of on the fence about this. I don't think there's any rheumatologist in the country that is naive enough to not use steroids, but some people are starting steroids and Actemra simultaneously. And keep in mind, getting a biopsy is not always easy, and getting it read right is even harder. So it's often clinical judgment, and if you ever see me write in the chart that they have a working diagnosis of giant cell arteritis, it means my clinical suspicion is really high and the biopsy was either not done or it was negative. Because the skip lesions, as they call them, even a good pathologist won't see if it's skipped that area that they're looking at. You can only slice so much. When you order a temporal artery biopsy, you want 2 sides no matter what, because it'll be on either side no matter where the headache is, and you want 3 centimeter pieces so they have a lot to work with. Now, whether you cut out 1 millimeter or 3 centimeters, your risk of scalp necrosis is the same. You've cut off the circulation. It doesn't matter how much you cut out. So don't look at me and say, 3 centimeters, that's crazy. 1 millimeter and 3 centimeters, as far as the circulation, is the same. You're not getting any more blood to go past that spot. But in terms of making the diagnosis, it might be helpful. So that's your number one large vessel vasculitis. Then there's extracranial temporal arteritis, where it affects the aorta. And I wanted to just quickly touch on, because I know we're running low on time, I want to tell you, you must know IgG4 related disease. This is a condition that is one of the leading causes of aortitis, in fact. So if you have, and we have one, I think I have 2 active cases now, 1 or 2. People that present with lethargy, malaise, and they kind of look like they could have cancer, they could have sepsis, they could have untreated any autoimmune disease you want, they could have lymphoma. And then when you do their imaging, they have soft tissue swelling along the entire aorta, or the aorta with the iliac vessels. It can be seen with or without retroperitoneal fibrosis. But again, large vessel vasculitis or disease, rheumatologically speaking. And by the way, again, go back to what I said at the beginning. They all can have joint disease too. So giant cell arteritis, you can get arthritis. Okay, I threw in here RP and BD. Relapsing polychondritis can present with large vessel vasculitis of the aorta. Behçet's disease can present with large vessel vasculitis of the aorta. So when somebody comes in with aortitis, you can't just automatically say, it's giant cell arteritis and it's just not involving the brain. Or therefore it has to be IgG4 disease. No, you have to really think in your head and ask the questions to exclude the possibility of Behçet's, relapsing polychondritis, and you need to do a bone scan, because there's a rare condition called Erdheim-Chester disease, which is a large vessel vasculitis that also involves osteitis. And so it's the aorta, and that's beyond your scope of necessary knowledge for this time. Okay, let's move on to medium and small vessel disease, because that's really where the action's at, or at least more to talk about. Medium vessel vasculitis, there's really only one. There is polyarteritis nodosum. So polyarteritis nodosum is a medium vessel disease, and typically the medium vessels are found within the organs, like the gut, let's say. So I mentioned before about symptoms. I said to you, sometimes you have to figure out what type of vasculitis somebody has based on their symptoms. So if you see a person who's got severe unrelenting abdominal pain, and you're just perplexed, you don't have any idea what's wrong with them. Like they don't have a rigid bored abdomen, you did an ultrasound, you did a CAT scan, you found nothing. And the person is screaming crazy in pain. They're like in a ball, they're just going berserk. I would suggest you probably give that person a lot of steroids and then figure it out after, because more than likely that person will have bowel wall edema, which means they got small vessel vasculitis of the gut. Because if they get medium vessel vasculitis of the gut, they're going to get a bowel infarction, and that will kill them. So